One of the treatments for prostate cancer is surgical removal of the prostate. This is recommended by a urologist or a specialist if the cancer of the prostate is a significant cancer, meaning that it has the potential to spread or ultimately lead to shortening of the patient's life. This treatment involves the complete removal of the prostate gland and the attached storage of semen organ called the seminal vesicles. By removing this whole area, when the cancer is contained, it has a very high chance of curing the patient of prostate cancer. It does, however, have certain side effects or potential side effects. One is the mere fact that it's invasive and of course will disrupt a person's life for a period of time. Two, it could affect the urinary control mechanism and can lead to temporary incontinence, that is, loss of urinary control, or in very small numbers, permanent loss of urinary control. Three, the erection nerves, which are very close to the prostate, can be injured, leading to difficulty getting and maintaining an erection. In addition to this, it can lead to other side effects such as hernia formation, bleeding, or other common post-surgical problems. The more experienced the surgeon, the less likely incontinence, impotence, and complications are going to occur. So what is a prostate? A prostate is a gland that occurs in men that manufactures a fluid called the semen, which supports the sperm made by the testicle. So indeed, all it is a fertility organ. It does not make hormones. It has nothing to do with urinary control, and it has nothing to do with erections. So if you have complete removal of the prostate, how likely are you to be cured of your cancer? Clearly, if it's contained, you'll be cured, and if it's spread further afield, you might not be. If you are not cured by surgery because it's more extensive, then sometimes you need follow-up therapy with radiotherapy. In addition, many urologists will remove the lymph glands adjacent to the prostate to maximize the chance of cure and to give a better idea as to what further therapy might be necessary. How do we know whether surgery really works? There have been several trials which have compared surgery to doing nothing and followed patients up for almost 20 years. And these trials have proven that surgery will decrease the chance of the cancer spreading and leading to a patient's death. So who is suitable for surgery? As I mentioned before, it's a patient with a significant cancer that is at least a Gleason 7, where the patient has a greater than 10 and preferably 15-year life expectancy, because these cancers are notoriously slow growing, and also a patient who's prepared to accept the risks of surgery and has had a good discussion about all the other treatment options. So I suppose the next question is, what type of surgery is the best surgery for you? Should you have open radical prostatectomy, robotic radical prostatectomy, or laparoscopic radical prostatectomy? The honest truth is that the surgeon is much more important than the technique that's utilized. In my own hands, now having done over 4,000 open radical prostatectomies and almost 2,000 robotic radical prostatectomies, in my hands now, the results are superior if I perform a robot-assisted radical prostatectomy than an open prostatectomy. However, that came after a learning curve of almost 500 cases. So it's important when choosing your surgeon that experience of the particular procedure they're using is high. What is robotic surgery? It's not a robot. All it is a very sophisticated computer that allows you to see better, 10 times 3D vision, use better instrumentation with greater degrees of movement in very tight spaces, and once you've mastered that technology, you can do keyhole surgery better with finer instrumentation with the potential of getting better results. Why call it a robot? I think that's a marketing ploy to actually make it sound more sexy. The honest truth is it's progress in technology that's allowing us to see better and do finer work in tighter spaces. So the common question now is robotic radical prostatectomy better than open radical prostatectomy? The honest answer is the surgeon's more important than the actual procedure. However, if you have best in class of both, the robotic slightly wins. In my own hands, there is a significant benefit in terms of 1, quicker recovery, 2, less bleeding, 3, decreased chance of complications such as hernias, 4, quicker return to normal activities, 5, slightly higher cure rates in early cancers, 6, quicker return of erections and quicker return of continence. In my hands, this has been published and it's evidence-based. This is a unique personal experience and it's not able to be extrapolated widely. So looking back over my career in robotic surgery over the last 12 years, what I found is the following. There is a learning curve, probably over 500 cases, before you've got consistently good results. Secondly, I do believe that there are certain cases, such as patients who are morbidly obese, patients with very narrow pelvises, or people who have had complex previous surgeries, where robotic does make it easier because of the enhanced vision and the enhanced instrumentation. With practice, it's possible with the robotic procedure to improve your outcomes in terms of cure, continence and potency, but again, this is very surgeon specific. In addition, complications are reduced, bleeding is reduced, hernia formation is reduced, and speed of recovery is sped up. Return to normal activities is improved. So all these advantages of the robotic do come with time. However, this is a unique personal experience and may not be able to be extrapolated across all surgeons. I'm often asked about the possibility of sparing erection nerves in a patient with prostate cancer. The truth is, it's really dictated by the details of where the cancer is and the findings at the time of operation. In the ideal candidate, such as the young patient with excellent erections where the cancer is clearly contained, erection recovery over 85%, sometimes 90% is possible. But in patients who are older, where erections are already waning, the results are not quite as good. With modern MRI, with my current level of experiences, and with thorough transperineal biopsy, it's possible to predict fairly accurately before the operation which patients can have successful nerve sparing. It's not black and white. Sometimes part of the nerve can be spared. The results are really dictated by the gentleness that you do the operation and how much of the nerve bundle you can spare. It's not a big yellow nerve, it's a bunch of fibres with arteries and veins which are very sensitive. So experience and care are paramount in getting the best outcomes.